I'm giving this presentation on behalf of Professor Gamal Ismat, who couldn't come for visa issues, but he sent me his presentation. This is not my presentation, this is his presentation, and I'm going to give it on his behalf. So it's about how to treat HCV in a resource-limited setting, the success story in Egypt. Let me remind you again of some demographics in Egypt. The population is around 96 million. The HCV antibody prevalence is around 7%. And the prevalent genotype for HCV is genotype 4 in 90% of those infected. The rest are genotype 1. This is the global prevalence and genotype distribution, and genotype 4 is again prevalent in Egypt, Syria, Saudi Arabia, and to a lesser extent in the Mediterranean. These are the trends in percentage of population age 15 to 59 testing positive for HCV antibody in Egypt. In 1996 data, the DHS data in 2008 and 2015, and you can see that the total prevalence in 1996 was 22.9% of HCV antibody, went down to 14.2% in 2008, and 10% again, down again to 10% in the Demographic Health Survey of 2015. This is the timeline for the HCV therapy, which started with standard interferon in the 90s, and then ribavirin was added, and then pegylated interferon set in 2000, and again with ribavirin. At that time, the best SVRs that could be achieved were around 50%. Then came the first generation protease inhibitors, tilaprevir and boceprevir, added to the interferon and ribavirin, and the response rate went up to 60 to 70%, and then the breakthrough of the DEAs and the interferon-free regimens with SVRs of about 95 to 100%, and this graph illustrates the success of DEA combos, different combinations of DEAs, achieving a 95 to 100% cure rate in patients with HCV. We now have highly effective DEAs that target different stages in the HCV life cycle, and this is the summary of the New England Journal of Medicine studies on interferon-free therapy in genotype 1 patients published in 2014, showing that the SVR is 96% in these patients. This figure shows the percentage of women and men with an active hepatitis C infection by age in Egypt in the Demographic Health Survey of 2015. And you can see that in both men and women, the prevalence of viremia increases with age, and you can see that the age group 55 to 59, the prevalence of viremia in the males is 27.8, quite high, and the prevalence of viremia in women a little less, 17.6. This is an alarming prevalence of viremia, but it could be explained by the fact that this age group was the age group that received parenteral anti-schistosomal therapy in the 60s, and this result of the Demographic Health Survey also, both in 2008 and 2015, show that males and females who received anti-schistosomal therapy, parenteral anti-schistosomal therapy, who had a history of parenteral anti-schistosomal therapy, had a higher prevalence of HCV infection. So this parenteral anti-schistosomal therapy is the cause of this high prevalence of viremia in the 55 to 59-year age group. The Egyptian Committee for the Control of Viral Hepatitis put in a strategy for the control of viral hepatitis in 2008. Through this strategy, 23 centers, treatment centers for hepatitis C were opened, distributed all over Egypt. The annual number of new patients treated for HCV, and at that time the treatments was pegylated interferon and ribavirin, was 45,000 people. The cost of each patient, the 1-year treatment, the 48-week treatment, was $2,000. So the annual budget for the Ministry of Health was $90 million per year. The total of number of patients that were treated with pegylated interferon and ribavirin during the period of 2007 to 2013 was 350,000 patients. At that time, Egypt negotiated the price of pegylated interferon and successfully reduced this price to $2,000 for the 48 weeks of a treatment. This was the lowest price for pegylated interferon worldwide. When sofosbuvir set in, again we negotiated the price for sofosbuvir, the brand, and successfully reduced this price to $900 for the 3 months course of treatment instead of the $84,000 in the US. And when DEAs became available, we were able to treat much more patients for HCV infection, because in the interferon-based therapy era, so many patients were not eligible for interferon therapy. Patients intolerant who developed side effects to interferon, patients intolerant to ribavirin, patients with autoimmune conditions, patients with hepatic dysfunction or decompensated cirrhosis, and patients with severe heart disease and pregnant females, and patients at a risk of neurological side effects. So when you rule out all these patients not eligible for interferon therapy, you end up with only a small proportion of patients with HCV infection receiving treatment with interferon. On the other hand, with DAA therapy, you can treat all these patients. You can treat patients who are cirrhotic, patients with comorbidities, patients with renal impairment, patients with psychiatric or neurological disorders, and drug users, and transplant patients, and even patients with decompensated cirrhosis. And because we can use DEAs, interferon-free DEA therapy, in so many patients, the number of treated patients in Egypt has increased dramatically with the introduction of DEAs. We used to treat 45,000 patients a year. Now, in 2016, we treated 600,000 only in 2016. So 600,000 patients in 1 year. It's not working, okay. The interferon-free regimens that have been used in Egypt are the SOF plus ribavirin for 6 months, the SOF plus simiprevir for 3 months, and the SOF plus daclatasvir or SOF plus lidipasvir for 3 months, plus or minus ribavirin. And in the last 3 years also, paritaprevir, ombitesvir plus ribavirin was introduced for the treatment of HCV in the Ministry of Health. So after the introduction of DEAs with the high efficacy and safety, it made our program very ambitious, and our aim was not only to treat patients with HCV infection, our aim was to decrease the prevalence of HCV from the 7% rate to less than 2%, and then less than 1%, and eventually eliminate HCV from Egypt. But this is not an easy job. There are several barriers. You have to decrease the incidence of new infections. Treating patients is not enough. You have to decrease the incidence of new infections. You have to look for the ideal drug that can be used as a mass treatment for all patients in Egypt. And then you have to do the logistics for mass treatment, for treating patients on a high scale. So to decrease the incidence, blood safety has to be ensured. You have to avoid unneeded injections. Autodestructive syringes should be used. Infection control measures should be very strict. And of course, awareness of the methods of transmission of HCV and how to avoid infection. And case detection and treatment by the ideal drug is also a means of preventing new infections. Can treatment impact HCV spread? Yes, it can, if treatment is applied early in the course of infection, because it was calculated in Egypt that each HCV infected person, during his lifetime, he can infect 3 other normal individuals. So if you treat the patient early in the course of the infection, you are going to prevent him from infecting others. The efficacy of the regimen used should have a cure rate of more than 80%. And patients contributing most to HCV spread, the so-called super injectors, are targeted preferentially for treatment and prevention. So new actions were set in the action plan of the Ministry of Health to increase policymakers' commitment to supporting the policy change necessary to prevent viral hepatitis transmission, to educate healthcare workers to prevent transmission of viral hepatitis in Egypt, to increase public awareness of viral hepatitis prevention, promote safe injection practices in the community, and to treat at least 200 to 350,000 patients a year and scale up the centers, increasing the number of centers from 23 to 46 centers in 2015, aiming to reach 100 centers by the end of 2016. What about choosing the ideal drug? We successfully introduced sofosbuvir into the market, and then cimiprevir, and then the brand of daclatasvir at very low prices, 1% of the USA price. And then the real revolution came to Egypt when we succeeded in introducing generics in the treatment of HCV in Egypt. Because generics, the price of generics were 15% of the price of the brands after reduction after negotiating the price and reducing it to 1%. So it was 15% of the low negotiated price. Just to show you how this made a difference, the cost of 3 months of treatment of SOF plus DACLA per patient with the brand versus the generic, the cost for the brand was 10,545 Egyptian pounds. The cost of the same treatment with the generics was 1,527 Egyptian pounds. This 1,527 Egyptian pounds is about $88. So it's $88 for the 3-month course of sofosbuvir and daclatasvir. And this was the regimen that was chosen for the mass treatment of HCV patients in Egypt. It's a very effective regimen, very high SVR rate, more than 95%. It is a very safe regimen. It is a pan-genotypic regimen. It is a very cheap regimen. This reduced the cost of treatment by 85.5%. So let me give you an example of how much money we saved in 2016 when we used, because we started using the generic SOF-DAC January 2016. So in 2016, we treated 600,000 patients with SOF plus DAC. This saved 5 billion, 0.3 Egyptian pounds, than the cost of the brand. So in 1 year, we saved 5 billion Egyptian pounds. And this is how you convince politicians to support mass campaigns for treatment. When he finds that you save him 5 billion pounds, definitely he gives so much support to the campaign. And now the president is asking for screening of 45 million Egyptians, starting the 1st of October, starting 1st of July, and ending June 2019. So, and this project already started, and we plan to screen 45 million Egyptians and to treat those who are infected. These are the number of treated patients through the Egyptian National Treatment Program with DEAs till the end of 2017. These data are updated December 2017. 1 million, 0.3 patients were treated. Most of them didn't pay for the treatment. Either were supported by the government, 60%, or by the health insurance organization, 22%, or by military and police hospital because they work there. So only 15% of the patients paid out of their own pocket. They willingly paid out of their own pocket because the treatment is cheap, only about $88 per 3 months, whole course. And now it's even less. It now costs $75 for the 3-month cost of SOF plus DAC. With this regimen, we can also safely use the regimen in patients with multiple or comorbidities, taking multiple medications, because the drug interactions with this regimen are few. So it's safe to use this regimen in many patients with comorbidities, and we know that many of the patients with HCV, especially in the 50 to 60-year age group, have different comorbidities. These are the several publications, international publications from the Egyptian HCV program for those who are interested to read more about the details of this program and its success. And this is a summary of the cure rate for the different regimens that have been used in Egypt. SOF plus interferon plus pegylated interferon plus ribavirin achieved a 90% cure rate. SOF plus ribavirin is 78% cure rate. I'd like to just to draw your attention here that at that time we used the treatments of ribavirin in the interferon ineligible patients who were cirrhotic patients, patients with advanced fibrosis. So this explains the low cure rate in these patients. The results of SOF-SIM were 93%. The cure rate with SOF-DAC was 97%, and the cure rate with SOF-DAC and ribavirin, which was used in patients with advanced fibrosis, was 96%. Now to how to implement mass treatment, how to treat 600,000 patients per year. The patients apply over the web, they apply online. In about 2 to 3 days, they get a response. They are assigned to one of the centers that will give them the treatment. They go to this center and they receive the treatment within 2 to 3 working days. The patients registered online for appointments till June 2017 were 1.6 million individuals. More than 150 treatment centers affiliated to HCV National Treatment Program in Egypt dispensed the treatment to these patients. They were operated by healthcare professionals, hepatologists, infectious disease specialists, and physicians who were trained to give the treatment and to follow up the patients during and after the treatment. And actually, these centers later on became centers for treatment of hepatitis B and for screening of hepatocellular carcinoma. So we use this infrastructure to support the HBV and the HCC program. The aim, as I said, became to reach a 2% infection rate in 2025 and to go down to less than 1% prevalence rate of HCV in the community by 2030. This necessitates treatment of 350,000 patients per year, and we already exceeded that target because in 2016 we treated 600,000 patients per year. And starting July 2016, there were no waiting lists. Everybody that needed treatment was treated or was initiated treatment within 1 week of applying. But, and this is the timeline for the treatment protocols in Egypt, SOF, interferon plus ribavirin was introduced in 2014 and till December 2015. Sofribavirin was given to the patients till from December 2014 to May 2015, and then was shifted to SOF plus SIM. And starting January 2016, all patients received interferon-free, an interferon-free regimen consisting of sofosbuvir plus daclatasvir. Where was Egypt before 2014? There were 6 million, an estimated 6 million individuals infected with HCV, but only 20% of them were diagnosed, knew that they had the HCV. 30% only were interferon eligible and received interferon treatment, and the SVR was 50%. So the calculated cure rate for HCV was only 3%. In 2017, still we have the same problem. The number of diagnosed patients is only 20%, but the cure rate went up to 90 to 95% with the directly acting antivirals, and the SVR, because it's very high, stepped up the cure rate of HCV to 16%. So we need to increase this purple bubble, the bubble of diagnosed patients. It's all about increasing this bubble that we can achieve a decrease in the prevalence of HCV in Egypt. So a screening program was started in Egypt, January 2017. 3.3 million individuals were screened till August 2017. The stakeholders were the MOH, the Ministry of Health, the Ministry of Administrative Development, the National Bank, and NGOs. This slide shows how NGOs contributed to this campaign. And you can see Messi, the famous football player, campaigning for the treatment of HCV at the pyramids. And this, of course, had a great impact on the population. As I said, the screening program was launched in January 2017. 3.3 million were screened till August 2017. 1.5 million of these fell into 6 categories: inpatients of hospitals, healthcare workers, prisoners, first-year university students, those who applied for travel abroad, and blood bank donors. The remaining 1.8 million was field screening in Upper Egypt. Upper Egypt is the southern part of Egypt, and this screening was applied to all age groups. So these are the results of the screening. The screening in this population of 3.3 million showed that 8.8% were HCV antibody positive, and out of these, 14% were HCV RNA negative. So the current national treatment program consists of 172 centers distributed all over Egypt, 71 belonging to the National Committee for the Control of Viral Hepatitis, and 101 belonging to the Ministry of Health. This is the plan. We hope that by screening, we increase the purple bubble from 20% to 90 to 95%, aiming to achieve a cure rate from HCV of 90 to 95%. We had designed a model to know how we can achieve a less than 1% infection rate by 2030. In this model, to achieve this less than 1% prevalence by 2030, you have to treat 325,000 patients annually, and we already exceeded that target. You have to increase the newly diagnosed cases by 340,000 per year in order to keep up and to have a continuous supply of patients that should be treated, otherwise we will run out of patients. And you have to treat all patients with HCV disregarding the fibrosis rate. All patients should be treated. If we succeed in accomplishing this, we will decrease decrease the number of totally infected HCV patients by 95% in 2030. We will decrease the number of patients with decompensated cirrhosis by 87%. We will decrease the number of compensated cirrhosis by 88%. We will decrease the number of HCCs by 85%. In recognition of the efforts done by the Egyptian government for the control of HCV, the World Hepatitis Day, Egypt was chosen to host the World Hepatitis Day in July, on the 28th of July 2015. And the Lancet Gastroenterology and Hepatology, in its first edition, chose this image on its cover in recognition of the efforts done by the Egyptians to get rid of hepatitis C and to save the liver of the Egyptians. And the Financial Times published several articles showing how impressive this program is and how it will impact the morbidity and mortality from liver disease in Egypt. From the land of history, we will make HCV a history. Thank you very much.